Hello, my name is Christina McGann, and I'm going to be talking to you about carrier screening, cystic fibrosis, and spinal muscular atrophy. Cystic fibrosis, also CF, is the most common autosomal recessive disorder. It causes the body to make thick, viscous secretions that affect the lungs and pancreas, as well as other organs in your body. It's more common in the non-Hispanic white population, and the life expectancy of somebody with cystic fibrosis is between the ages of 32 to 50 years of age. Spinal muscular atrophy, SMA, is also an autosomal recessive disorder. It's the second most common autosomal recessive disease. It causes muscle atrophy, is debilitating, and often death by the age of 2. There are several different forms of it. And the most common form is the one that causes the death by the age of 2. It's not limited to any one ethnicity. Carrier screening, the description in history is that carrier screening is a genetic testing done to determine if a person is a carrier of an allele of an autosomal recessive disease or disorder. Carrier screening for cystic fibrosis started in 2001. Carrier screening involves obtaining a blood or tissue sample. When you're doing a tissue sample, it's usually a swab to the inside buccal cheek. Carrier screening sensitivity and specificity. It has a high sensitivity rate, meaning if you're positive, like it's more than 99% likely that you have the mutation that was tested for. However, a person being screened needs to be aware that they may still be positive for a mutation that wasn't tested. So in the case of cystic fibrosis, you might have come back negative for all of the mutations that they tested, but could still be a positive carrier of a mutation that was not tested for. Indications for carrier screening. They say cystic fibrosis and SMA carrier screening should be done at preconception appointments, if possible. If not, then at the first prenatal appointment. The number of mutations tested is based on the ethnicity and family history. And when I'm discussing that, I'm talking about other screening as well. For instance, anybody with African American ancestry would want to test for sickle cell. That's what I mean by the number of mutations tested, like with different ones of that. And there's different tests that you can order that specifically test for different anomalies. Not anomalies, but differences. All females should be screened for cystic fibrosis, SMA, thalassemia, and Fragile X syndrome, per those that you see there. And that's what the American College of Gynecology and Obstetrics and Gynecology states. A minimum of 23 mutations should be included in the screening per the American College of Medical Genetics and Genomics. The character screening indications, continued, is that genetically female partner should be screened, and if positive, then the genetically male partner should be screened. So if our pregnant born woman comes in and we screen her and the screening comes back, the carrier screening comes back positive, then as the provider, my next step would be to have the genetically male partner screened as well. If both parents test positive for an allele of a mutation, then chorionic villi sampling at 10 to 13 weeks of gestation or amniocentesis should be offered. You can do an amniocentesis throughout the entire pregnancy. I'm not going to get into those details because I believe somebody else is doing those. If the patient receives a positive result, genetic counseling should be done. That's the ACOG guidelines. However, when discussing doing carrier screening, it should be offered that we could send for genetic counseling even before the test is done. Contraindications are that carrier screening does not need to be done if the patient has already been screened for that disorder or disease previously, and we have proof of that we can see. Since it's a genetic disorder, if they've already been screened and it's negative, then it's going to still be negative for those same mutations if we try to screen again. The procedure is we need to first discuss the importance of carrier screening with the patient and the partner if present. educate the patient, and receive informed consent from the patient. At this point, if they don't want the screening, it's up to them, and we would just try to reiterate with education. And then if they do give us informed consent, we need to order the screening that is inclusive of all potential autosomal recessive genetic disorders of the patient's ethnicity. So not just cystic fibrosis and SMA, but like I discussed previously, you would add in the ones, for instance, if they have African American ethnicity, you would want to add in your sickle cell. The procedure continued is that you would obtain a blood sample using sterile technique, like, since we're all nurses, we should know how to do, and send it to the lab that's covered by the insurance and able to perform the test or send the test out, because some labs don't have the ability to be able to do different tests. And if we're not at a facility or able to obtain the blood sample ourselves, then we should order the carrier screening and send the patient to the outside laboratory for collection and testing that both can either test within themselves or send out the test and are within the patient's insurance providers. And then we want to make sure that we refer the patient to a genetic counselor and maternal fetal medicine. I put those like with a or they're like a, because where I'm from in Las Vegas, our maternal fetal medicine is the genetic counselor. That's where they're at. So I'm not sure if around the country if you have like genetic counselors that aren't part of maternal fetal medicine. And at this stage, you wouldn't need maternal fetal medicine because we don't know that there's any issue. You would really just need a genetic counselor so that the patient could ask more in-depth questions and get more in-depth education if they so desired. Advantages of carrier screening include the patient would know that they're a carrier for the genetic disorder. If both parents are carriers, then further testing could be done to determine if the fetus has inherited this disorder, in which case there would be a 1 in 4 chance of the fetus having the autosomal recessive disorder. It would allow parents time to grieve the healthy baby that they thought they were having and prepare for a baby with a genetic disorder if further testing shows that the fetus did indeed inherit the disorder. And it also allows parents to learn about the disorder, and if we know that the fetus has a disorder, it allows them to go to the hospital, be in contact with a hospital that's capable of caring for the newborn, depending on the genetic disorder. Some newborns need to be treated at specialty hospitals that can care for them. Disadvantages of carrier screening. An obvious first one is that there's the fear of the unknown for the patient while they're waiting for the results. You've just kind of like shocked them into the fact that they may not have this textbook perfect pregnancy or textbook perfect fetus, and so they'll be afraid of that. Negative results do not mean that a different mutation is not present, so that's one disadvantage, because you could, like I talked about earlier, you could still test negative for cystic fibrosis and then actually still be a carrier. I shouldn't say negative for it, but negative as a carrier, but then still be a carrier because it could be a mutation that was not tested for. Of course, there's additional cost and time to the patient. If they can't get the blood just drawn there, then it will require more time for them to go to an outside lab. It would also require more time if they chose to go to genetic counseling. And of course, there's the additional cost based on their insurance or if they have insurance. And then positive results of both carriers can lead to more invasive testing to determine fetal well-being, as I discussed earlier. So normal findings of carrier screening for cystic fibrosis and SMA include negative for genetic mutation screened, and that would indicate normal findings. Education for normal findings or negative screening would include that there's still a small chance of being a carrier because tests cannot check for every mutation or gene. Action by the provider would include having the patient return in 4 weeks for their regularly scheduled prenatal appointment if they're already pregnant. If they're not pregnant, then you would just give them the signs and symptoms of when to return, including missed period, overactive, like sensitive breasts, things of that nature if they believe that they're pregnant, to come in to have a pregnancy test if they're going to be trying. And then you want to answer any questions that the patient and or partner have at this time, and discuss any feelings that they may be experiencing, and allow them to voice how they're feeling, and that helps create a good relationship between the two of you that would carry on throughout the pregnancy. Abnormal findings of a carrier screening included for cystic fibrosis and SMA would be a positive for a mutation. And a positive would require discussing options with the patient, including genetic counseling if they have not already gotten or been offered that, referral to maternal fetal medicine, and carrier screening testing of the genetic father of the fetus, if we know who the genetic father is. Obviously, if we don't know who the genetic father is, then we would skip that step and just want to refer to genetic counseling and to maternal fetal medicine. Next, we would want to educate the patient on the need to let her family know that she's a positive carrier for whichever mutation it is. And so for my presentation, I'm talking about cystic fibrosis and SMA. Because it's a genetic mutation, it's possible that close relatives could also have the same disorder, and we would want women of childbearing age to be tested as well to rule out or find that they have the same mutation. And we also want to educate the patient on the fact that she's a carrier for the disease, and a brief overview of cystic fibrosis that I gave at the beginning, probably a little more in depth because obviously we're all nurses already, or of the SMA, including, again, a little more in depth than the shot that I gave you. Carrier screening abnormal findings continued are that you want to contact maternal fetal medicine to discuss the patient and referrals so that they're aware. And then depending on what part of the country you're in, some of them, the patient's responsible for calling maternal fetal medicine and saying that they have this referral they need. And in some places it's insurance companies, and in some parts of the country it's actually the maternal fetal medicine office that will call the patient to set up the referral. And then we want to refer to genetic counseling, like I said, which in some parts of the country is the same as the maternal fetal medicine. And then we want to make sure that we're supporting the patient during this emotionally trying time. Schedule the patient to return in sooner than the normal 4-week period for the next appointment, so that you can just make sure that she's followed up, or listen to her reasons for not wanting to follow up, talk with her. Then you would want to educate her and support her in her choice that she doesn't want it. Educate her, make sure that she understands the risks of not carrying through with further testing or having her partner tested, and then be there to support her through the pregnancy, which would probably include more frequent ultrasounds so that you can be watching closely for growth. And then you want to follow up via telephone also, not just wait for the patient to come back, but you want to follow up yourself via telephone and see if the patient was seen by maternal fetal medicine. Does she have any questions at this point? And does she need an earlier appointment so that she can see you and talk about the situation? These are my references. Here are the first 3. 2 more. And 3 more. I hope this helped you with a better understanding. It wasn't really supposed to be as much on what cystic fibrosis and SMA are, because those we've already gone over, but more of the testing and care of the patient that's being tested or comes back positive. Thank you.